Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical. This is Dr. Arshan. And I'll be your mentor for the AMC Clinical Preparatory course that's going to start from 31st of January this month. I hope you guys are doing good. So let me start with a very good news that the 2021 was a very, very good year for us, especially for the First Aid AMC Clinical group, because we are very much proud and honored to announce that there was the highest passing rate among our candidates in the last year. And I hope that this will go on for the years to come. And this is only possible because our candidate actually showed a lot of compassion, hard work, dedication. And along with that, we also tried our best to provide the necessary classes and also a very good format to prepare their clinical exam. Now, you understand that this is a hard time for everyone. It's not for only you guys, it's hard for every single person around the world, right? So this COVID situation has crammed up a lot of problem throughout these 2 years. A lot of your exam has got canceled in MCQ. Even some of you are here who might also appear the exam or already prepared and trying to get an exam date. So I know that this is a hard time. And during this hard time, we tried our best to provide adequate amount of support to the candidates. And look that how our candidates actually thrived in the last year. That was amazing. We're really proud to be a part of their journey. You can see that every month, the passing number of students that pass from the course is really, really wonderful. I have been teaching for a long time, but this amount I haven't seen previously. So obviously, we are also very, very proud to announce this kind of result. So you guys are going to be a part of our group, most of you, as I can see that a lot of you from here already enrolled the course. So that's a good start. Now, tonight class is a free review session. And the most important topic for your AMC clinical is psychiatry. And if you are good in psychiatry, it means that you are good to take history, you are good to talk with someone, and also you are good with the whole clinical scenario that usually they ask you. In the exam, especially for AMC clinical, you know that it's not very easy to pass the exam. And by that, I mean that not everyone passed the exam. And that's really a fair thing, because even if you are going to appear any exam in your country, let's say like any exam which is going to make you a specialist, or maybe you're going to get a degree out of that exam, that the last part of that exam is always hard. So whatever exam you're going to appear in your life, the last part is really, really hard. So in AMC, part 2 is your last part, right? So it's going to be hard, and it is normal that they are not going to pass everyone like the MCQ. MCQ is a lot easier to pass, but it's not something like impossible. Many of you will get a lot of bad vibrant or bad vibes from your friends, from your relatives, from your colleagues, that no, AMC clinical is not easy to pass. Or sometimes even they say that it's impossible to pass. And you guys, if you are in our First Aid AMC Clinical official Facebook group, you can see that every month our candidates are passing. And that means that it's not impossible, obviously. And most of the candidate who is passing, their first time candidate. That means just first attempt, they pass their exam, which is really, really good. So don't lose your hope. If you are doing good, if you're doing hard work, you're giving enough time for your preparation, and have someone on your behind who can give you the guidance to know how to prepare for this exam, you are going to ace the exam. All right, so that you just need a good support, good plan, and if you have those things, then obviously you are near to pass the exam. Now, before I move into the psychiatry review session, let's discuss a little bit about how AMC Clinical works. You need to know that because this is how you will start your preparation. And I'll try a little bit today that just to start that how you should start your preparation, because many of you are here who just passed your MCQ exam, right? So for you, it's totally new. And I'm going to just give you some idea. And there is a 2-week free review session coming up from 31st of January. So in 2 weeks review session, that's totally free for any one of you. Even if you don't want to join the course, you can join that initial 2 weeks just to get an idea about how you should prepare for clinical. All right, so in these free sessions, we will go through the initial approach, how you should prepare yourself, and a whole lot of other information. So you will get the schedule for the free 2-week session, maybe in 2 or 3 days' time in the Facebook group. First of all, AMC clinical exam means that it's an OSCE type of exam. That means there will be clinical scenario, just like long case that you used to do it in your medical college or medical university. So OSCE means that there will be 16 stations for your exam, and there are 4 rest stations. So together there are 20 stations in the exam. Among those 16 stations, 2 will be pilot station or non-scored station, and 14 will be scored station. And if you pass 10 out of those 14 scored station, then you pass the exam. So that's all. You pass or you fail. There is no retake. There is nothing in between. That day is gone. Okay. Previously, you can do a repeat or retake of that exam with a small amount of cages, but now it is either you pass or you fail. Okay, so to pass, you need 10 out of 14 stations. Now you know that now there are 2 formats of exam, and you need to be aware of the fact that COVID is not going away from your life, most likely in the next 1 or 2 years. So most of you will be appearing the online exam. And that's a fair thing to say. And I know that in the last 6 months, there was just like a normal life kind of thing started. And people used to start going to the face-to-face clinical exam in Melbourne. But that's most likely not going to happen. As you can see, the February and March exam is canceled. So there will be more cancellation of face-to-face if this COVID things goes on. And most likely it will. So in that case, I would suggest that prepare for online exam as well. And on the background, also know how to appear the face-to-face exam, because if things gets better again, most likely maybe in May or June, things will get more easier, then you might be able to appear the face-to-face one. So you need to know the both format, because getting an exam that is really, really hard. So that's one of the logging, or you can say there is a backlog happening at the moment. A lot of candidates for the last 2-3 years trying to get into the exam. So it's sometimes it can be very hard just to get an exam date, and passing the exam is another hard thing. So for that reason, you should take the best one or the most available format that you can appear. So if you are fully prepared, you will not just wait for an online exam to get opened. You will be prepared for both online and face-to-face, so that any chance comes in front of you, you can go for the exam when you think that you are confident to appear the exam. Okay, so Face-to-face and online is mostly same. The main difference is in the physical examination, because as you understand, in online physical examination, you can't do it on a patient, but in face-to-face, you need to do it on a patient. I have seen the last few exam, they are not going to like allow you to touch the patient even in the face-to-face exam. So in that case, things will be just similar like online. That means you go to the face-to-face exam, but you are just describing your physical examination in front of the patient, even in face-to-face. So one way or other, you need to know that how to describe physical examination to a patient, to a medical student, or to an examiner. So online format is must to know for at least the next 1 or 2 years. So you will be in that range. So I think like for you, yes, there is nothing like I will just go for face-to-face exam. It should not be like that. Okay. So that's a very good, I would say like it's something you should be smart in this kind of problematic areas, so that like you don't just wait for just to get an exam. So that should not be done. A lot of candidates actually done that. So that's why I just wanted to let you know about it. Now, how the exam happens. Let's forget about face-to-face and online. The format is important. So you get 16 stations. Each of the station is 10 minutes. You get 2 minutes outside to read the case and think about differential diagnosis or whatever you are going to ask. And then you enter the exam and you have got 8 minutes inside to deliver that case. So some of the tasks will ask you to take a history. Some of the tasks will ask you to go through the investigations, explain the diagnosis, differential diagnosis, management. So according to the task, you're going to use that 8 minute time to finish that task. All right. So that's the format. So that will happen in every 16 station in that way. Usually in between every 4 station, you get 1 station just as a resting station. And that's also very important to utilize that time, not to think about anything. Just use that time as a free time. Don't think what you have done in the past 4 stations, because if you just keep thinking that, you will destroy the other 12 stations in front of you. So that's another important thing to learn. The next one, in case of online exam, that's one of the important thing is that your appearance is important in an online exam. And that doesn't mean a lot of changes, but a couple of things I have noticed throughout the last few years when we started this online examination format. What happens is that somehow, because the examiner is a human being, somehow in human being, if your video is not clear, or your background is not clear, or maybe your kid is crying in your behind, and there is noise in the house just during the exam, even though you are very good, even though you are covering everything, there is a chance you might fail the exam. And that happens because it's an overall performance. If it's noisy, if you look very blurry on your video, that affects your mark somehow. Okay, they will never ever write it in their feedback, but it affects. So when you go for an online exam, make sure that they can see you perfectly. And also, like, before you go for exam, show, like, at least talk to your partner or your study buddies that how you look in the video, that are you looking clear? And also make sure the background should be very neutral color, like you can keep a white background without anything behind. If you're giving a white background in your behind, you should wear something. You can wear something darker color so that there is a match in between your background and the color that you are wearing. Okay, and there is no hard and fast rule about it, you will know that how you look in a video. And that's really important. And another important thing is that, let's say you look really like a gentleman or very, your dress up is good. You're looking gentle and polite, but you, your video is blurry or enough. And that's not your fault. It's the fault is your laptop that you are using. So I would advise, if you can, at least during the exam time, if you can use a good laptop which has a good video setting, or the camera is really like very good camera. If not, then you can buy a webcam which has a good pixel or resolution. Somehow you should look very clear. Your background should be nice and clear. You should wear something nice and gentle. You should not, like if you're a male, you should not just wear a t-shirt in front of an examiner. Okay, wear something formal. That's really important. I have seen a lot in the past 2 years when we are taking the mock exam. I've seen people just coming into the exam wearing just a t-shirt. So it's not like that. It should not be. I know that like Australians, they don't bother with that formality too much, but just for the exam part, you should be formal, even if you are not going as a face-to-face. So formality is important because you are appearing a formal exam. So these are like a very tiny little details that a lot of candidates forget out of pressure and nervousness of the exam. But that matters. You should make sure you know about it. All right, so that's a little bit chatting about the exam format and everything, but a lot of things will come across when we start the free 2 sessions. So let's start our session tonight, and then throughout the next few weeks, you will get to know the approach of the exam. And once you know the approach, it will be easier for you to understand how you should introduce yourself, how you should start your history, how you should start your physical exam. So you will get a format in your head, and that's really important. Now, First Aid AMC Clinical is famous to show the candidate a cluster-wise approach of preparation for your clinical exam. That cluster-wise approach is super concise form. And what happens with the cluster format is that you will understand that just by one history format, that same history you can utilize in 10 cases, and the 10 cases just done there. You don't need to prepare for 10 cases differently. So there are formats that we provide for you so that you just know one particular format, and you can utilize that format for at least 5, 6, or even 10 cases. You just need to know the management of those cases. That's all. And in that way, we can make sure that your preparation becomes very concise and well organized, rather than doing every cases differently. In that way, you will end up having 300 to 400 cases in your head. And then in the exam, you will mix it up. So that's something which we show to you throughout the course. Now, tonight class is about mini mental status examination, or MSE, famous for AMC clinical exam. Almost every one of you, I can say like at least 70% of you in your exam, you will get one psychiatry question from this mental status examination. Okay, and that mental status examination is all about how you take your psychosocial history, and also the next task they ask you is to present the finding to an examiner. So this is very important, that, and this psychosocial history you can use in every psychiatric history. And that's how your psychiatry becomes so easy in the end, that you know history, all, like, even though you don't need to remember it. All right, guys, just to check that, I can see some of you are in Facebook Live, some of you are in Zoom. Both of you are hearing me properly. Is there any issues? And feel free to ask me any questions, okay, if you don't understand anything during the lesson today. You guys can listen? Yeah? Okay, clear. Good. And those who are in the Facebook, we don't usually take classes on Facebook Live just because this is the first session with you. I know that many of you will not know how to join a Zoom session. So that's why I kept it open today. But the next class, which is going to start from 31st of January, that will be your 2 weeks free session that will not be live on your Facebook. So please make sure you come to the Zoom. The Zoom ID and password is given in your Facebook group. So make sure you just use that and join it. It's very easy to join a Zoom session. All right, so let's start. And those of you who are in the Facebook, if you have any question, just write it in the chat box or comment box. Whenever I can get some time, I will just have a look and I will try to answer your queries over there. And those of you who are in the Zoom, if you guys have any question, just write it in the chat box and I'll try my best to answer that question. All right, so now starting with the psychosocial history. The first thing in a psychiatric history is that you need to be very gentle. Do not rush your history because you need to make a good rapport with the patient. And good rapport and good relationship with the patient starts with a good introduction. And also, every psychiatric history needs a confidentiality statement. Confidentiality statement means that you are showing to the patient that the history that's going to, like the history they are going to tell you, you are not going to discuss this with anyone. And that confidentiality is must. If you don't give a confidentiality statement in the exam, most of the time they can fail you just because of that. And another important thing is that without a confidentiality statement, most of the role player are already designed in a way that they are not going to give you information. The thing is, if a role player doesn't feel that you are a safe doctor to discuss their personal issues, especially a psychiatric issue are always personal, they can withhold information from you. And that is actually given, this power is given by AMC to the role player. So if you don't give confidentiality, you will end up not having enough information. And if you don't get information, you can't give that information finding to the examiner. And what happens? You fail. So confidentiality statement is must for your exam, especially for psychiatric history. Now, there are two approaches of confidentiality. One is conventional, which is used by almost every candidate, but not our candidate. Our candidate uses an alternative approach, which means that it shows that they are coming from something different and they're not just coming to the exam, reading a Karen note or maybe some other note, okay? So conventional approach is you just say this statement that let me assure you, whatever we talk today, it's going to be confidential unless it is harmful for you or others. So that's the conventional confidentiality statement. It looks like a judge, or you can say a lawyer is giving this statement to a person. If you use this, that's fine. You will not, like they will mark you in the confidentiality thing, but eventually, because if 32 candidates say the exact same line, examiner gets bored about it. And whenever someone says something different, it sounds interesting and they like it. So try to be a little different than others. Don't just read some note and memorize it and then just deliver it like a vomiting. Examiner knows that you just memorized a note and then came for the exam. And no one will pass in that way. Okay, even though if you are following our note, you need to make a little change because you can't sound like you are just coming from reading a note. So you have to have your own approach. You can always take help from notes and everything, but you have to have your own version. And that's how you sound interesting. And that's how you get filtered out of those candidates. Okay, so this is important. Now, how we actually ask you to take a confidentiality statement is that, say in that way, nice and easy and frank. Say that, hi, let's say this patient name is Sam. Hi, Sam, this is Dr. Arshan, one of the doctor here. It's very nice to meet you today. I understand from the notes that you are having some tough time these days. Now, see the change of tone in my voice and the how the approach is getting a little bit of empathetic. That's important as well. So again, Sam, I understand from the notes that you are having some tough times these days. I'm really sorry to know about that, but I want you to know that we are here to help you. You can tell me what's making you really stressed. I want you to understand that you can be frank with me. There is nothing that will make me judgmental about you, and there is nothing you need to be embarrassed about. I get to know a lot of patients during my consultation, and there is nothing embarrassing that you can tell me. I want you to know that I'm here to help you in every possible way. But I need to know what's going on with you, and then I am able to help you. I need to understand that the conversation that we are going to have now, it is confidential, and I'm not going to disclose it to anyone unless it is harmful for you or others. Now, this sounds a long thing, right? But let's say, which one you will like as an examiner, the first one or the second one? Or even as a, like, let's say I am your doctor and you are my patient, which one you would like? Think in that way. You would obviously like the second one. I'm 100% sure about that, because you are trying to make the patient open up. And this is how, even in your real life, patient needs these things from you as a doctor, that they can feel safe with you. Another important thing, because some Australian will come to you, and obviously your accent and their accent doesn't match, and that's fine. You don't need to sound like an Australian in exam. As long as they understand what you are saying, you are fine. There is no need of having an accent like an English accent. No need. Okay? You just need to sound normal, and they need to understand you. You can't be very fast. You can't be very slow. You have to be in the middle. As long as you sound polite, gentle, and then they can understand your conversation, you're fine. So the polite, gentle change in voice and tone when you are talking to a sad person is important. When you are getting a good news from a patient, you smile and you show that you are happy for the patient. So that's how you change your emotion, so that patient understand that, yes, this doctor is listening to me. Okay, or let's say someone is sad and crying in front of you, and you started your conversation with a smiling. That doesn't go with the situation, guys. I have seen in the mock exam that patient is crying in front of you, but you are smiling as if that's nothing is happening in this room. If a patient is crying in front of you, you don't need to cry with her, because then that's become more crazy. So you don't need to cry with her, but you need to show your empathy by changing your voice, by changing the pitch of your voice, changing the tone, so that they understand, yes, this doctor can at least feel what I am actually going through. At least he is showing that empathy with me. And that's only thing the exam also wanted from you guys. So as long as you are able to do that, you will pass the exam. So as I always say to candidates, that it's not about how knowledgeable you are or showing that you came from a specialist background or you are a specialist in maybe an obs-gynae, maybe you're a cardiologist, maybe you are an ophthalmologist. They don't want you to be a specialist. They want you to be a junior doctor who is going to start their hospital or a GP as a junior doctor after passing this exam. So you need to sound like a junior doctor. So you don't need a lot of specialist knowledge to pass this exam. You need a good format. You need a good way of talking, and you need that your conversation is gentle, polite, empathetic when needed, and very fluent. Okay, so that your voice sound confident rather than feeling like you are scared in the exam in front of a patient. You can't sound like that. So you have to be very confident. You have to sound polite, gentle. As long as you sound like that, you will pass the exam anyhow. Okay, so initially you guys will listen a lot of this thing from me because I like the initial classes to show you the approach. And once you get the approach, then I just skip this part and then just go with the history and the other task. But initial few classes, you will hear this thing a lot so that it goes into your brain and stays there permanently. All right. So once you say that, you have given enough confidentiality, and then you can ask to the patient, would you please tell me a little bit more about it? Open-ended question always. Then if they like your approach, most likely they will open up. And then they will give you some information, and then you will go on with the history. Some of the psychiatric cases, especially if it's a depressed patient, even though you give a lot of confidentiality and everything, they might not open up. They will only answer you if you ask questions. So in that case, you have given enough confidentiality reassurance, then you can start your question. So in psychosocial history, the format that you guys should follow is that start with mood, sleep and appetite, suicidal risk, hallucination, delusion, insight, judgment, cognition, heads, SADMA, past medical history, family history. So that's your headline. Now let's go in detail about these things. So first question is that, how's your mood these days? Patient says, yes, doctor, that's all right. Then you don't need to ask any more question. Patient says, it's mostly low, doctor. So what you can ask at that time that, how long you are feeling this way? So get a duration. And also you can ask that, anytime do you feel really high? So that's to rule out bipolar disorder. So if you get a low mood, ask these two questions at that time. After mood, ask about how's your sleep and appetite. Patient might say, I'm having sleeping difficulties. If patient has sleeping problem, then there are a couple of questions you need to ask. One question that, do you have difficulty falling asleep? If someone having difficulty falling asleep, that's most likely anxiety-related issue. Or do you wake up early in the morning? Waking up early in the morning, that shows depression. Or your sleep gets broken multiple times at night. Now, multiple time broken sleep can be related to a lot of condition, anxiety, depression, but most of the time it can be a nightmare which is causing that. And that suggests post-traumatic stress disorder. If patient says sleeping is breaking multiple times at night, ask that, do you get any nightmare? If you get nightmare in the sleeping, you should ask the PTSD question at that time. So we will not go with the PTSD question today. We will do it later on when we do some more psychiatric questions. So that's your sleep and appetite questions. After sleeping and appetite, the next question you ask is suicidal risk. Very, very important question. Any psychiatric question, suicidal risk is must. So what question you can ask for that? You can ask that, do you feel or do you think that life is worth living? If you forget this one, you can also ask that, do you have any passing thoughts of harming yourself or others? Now, as you can see the questions, in AMC Clinical, you can't use any medical jargon with a patient. Everything that you ask, everything that you discuss should be non-medical jargon. Okay, that means you can't ask to the patient that, do you have suicidal thoughts? You can ask it, patient know what is suicidal thought, but normally we will try to be more simple with the patient. And you can't ask that, do you get hallucination? Patient will ask, what is hallucination, doctor? Then you will define hallucination and you will just waste your time. Remember, you don't have enough time in exam. The time is really, really hard to finish the task. So you have to be very, very well organized in the exam. You can't waste any excess time. So for suicidal risk, you ask that, do you think life is worth living? Yes, doctor, I feel life is worth living. Then you don't need to ask that, do you have any passing thoughts of harming yourself or others? If patient says, no, I don't feel my life is worth living, then you can ask that at the moment, do you have any passing thoughts of harming yourself or others? If patient says yes, the next question you ask is that, do you have any definite plan? Or do you have any access to any weapons? Have you ever attempted any suicide before? So these are the questions if you get a yes in these two questions. Like no in here and yes in this question. That means patient is having active suicidal thought. You need to find out if they have any definitive plan, if they have any access to any weapons and any previous attempts. Once you have done the suicidal risk, the next question is, I'm going to ask you some screening questions that may seem quite strange to you. Is that all right with you? I always say this thing before asking hallucination delusion question because patient thinks that you think that patient is crazy or insane. So that's why you just give a prompt before asking this question that I'm going to ask you some sensitive question or screening question that may seem quite strange to you. Okay, so that's how you start your question of hallucination and delusion. Sometimes in here, like not a MAC case, in other cases like depression, anxiety disorder, PTSD, we also add some questions related to that specific disease or a specific condition. So in MSc, we don't add any more question, but let's say someone, you need to take a history of a depression and diagnose depression. At that time, we add questions for depression, we add question for mania. So depending on the presentation, we might need to add some specific question for a specific condition. But for MSc, mental status examination, we don't need to add anything. So for MSc, the psychosocial history is mood, sleep, appetite, suicidal risk, followed by hallucination and delusion. So for hallucination, only one question. Do you see, feel, or hear things that others don't? So C is visual hallucination, then feel tactile hallucination, and here is auditory hallucination. So in one question, you are asking 3 hallucination questions. And in mental status examination, hallucination is defined by perception. We'll discuss the aseptic J3R in few minutes time. You will know what I am talking about. So perception, like hallucination, is a perceptual disturbance. Okay, so in MSc, if we are talking about perception, that's all about your hallucination. Next question is delusion, which is mainly you will get both hallucination, delusion are present in a schizophrenia patient most of the time. Apart from that, delusion can be there in a lot of other things, like you can get delusion of guilt, in a depression patient. You can get grandiosity or delusion of grandiosity in a mania patient. So depending on your case by case, there will be different type of delusion positive. So to remember the delusion, you can remember RCGGP. So what is RCGGP? R for reference. So that's delusion of reference. Then you have C for delusion of control. G for delusion of guilt, delusion of grandiosity, and delusion of perception. Delusion of persecution. Persecutory delusion or paranoid delusion. So that's your delusional question. One by one, you will ask it. Now, you can't ask in that way. You have to ask in a simple way. So for delusion of persecution, we ask that, do you think someone is spying on you or trying to harm you? If patients think that someone is harming them or someone is trying to murder them, someone is trying to spying on them, that's paranoid or persecutory delusion. Do you think someone is controlling you? That's delusion of control. Do you think people in the street are talking about you? If patient says that, I think my neighbors are always commenting about me. If they say that people in the streets are always talking about me, that's delusion of reference. Do you think you are guilty about something? That's delusion of guilt. Most of the time, you will get it in a severe depression patient. Do you think you have some special power? That's delusion of grandiosity. So that you will be positive in case of bipolar disorder or mania patient. So these are the delusion question. Apart from these 5 questions, there are also some other delusion questions. So those are called thought insertion, thought withdrawal, thought broadcasting. So do you think someone is inserting or withdrawing thoughts from your mind? Do you think your thoughts are being broadcasted in TV, newspaper, or radio? So if a patient says that, I think something funny is going around me, and the TV, newspaper has always some information about me, that means patient most likely having thought broadcasting. Or you can say delusion of thought broadcasting. So do you think someone is inserting thoughts in your mind? So that's thought insertion. Withdrawal is thought withdrawal, and another is thought broadcasting. So these 3 are also under delusion. So always try to rule this out in a patient who is most likely having schizophrenia. Once you have done your delusional question, then you ask insight, judgment, and cognition question. For insight, do you think you need some medical help? Patient who doesn't have insight, they will say, no, I don't need any help. For judgment, if there is a fire in this room, what will you do? So patient who has poor judgment, they will say, oh, I will not do anything. Fire cannot touch me. I am the messenger of God. So that's having a poor judgment. If patient says that oh, there is a fire in this room, where is the fire? That's called, they sometimes also have, like, they can't understand proverb, or they have some, like a thought disorder, you can say. So they don't understand your conversation most of the time. That sometimes we call as poverty of thought. So that's one of the other finding you can get. But if someone say, yes, I'm going to run away, that means they're having a good judgment. Then come to the cognition. Cognition, we usually try to find out if this patient having enough cognition in terms of time, place, and person. So 3 questions. So do you know where are you at the moment? That's the place. Do you know what is the date today? That's the time. And do you know who I am? That's the person. So you need to find out if this person is oriented to the time, place, and person. So after you have asked that, this usually will give you all the information that you need to present MSc to the examiner. To wrap up the case, you can just finish with heads, SADMA, past medical history, ruling out organic cause, and family history. So what is heads? Heads is a mnemonic for a lot of things, but we don't go for all the things in the heads. So H is for home situation, E for education or employment, A for activity, D for drugs or diet, S for social history, another is for sexual history. So these are all the heads that we ask, but for your psychiatric history, just keep the home situation and work situation and the support. That's all that you need to ask. So ask that, how is your home situation? Are you a happy family? Do you have any stress at your home? Do you do any work? If yes, then is there any stress at your work? If patient doesn't work but is studying in a university or in a high school, then do you have any stress in there? And do you have enough support? So that's the only heads question that you need to ask. SADMA. SADMA, again, is a mnemonic for a lot of things: smoking, alcohol, drugs, medication, allergies. So normally you ask smoking, alcohol, you ask medication. Sometimes you can also ask about recreational drugs. Okay, so do you smoke or drink alcohol? Any other recreational drugs? Past medical history, any past history of mental illness, any family history of mental illness. Sometimes you can rule out organic causes just by ruling out, especially we try to ask 3 things to rule out organic cause: hypothyroidism causes or hyperthyroidism, head injury, and any recent flu. Sometimes these 3 medical or organic cause can mimic psychiatric causes. So that's why we just ask this question: any change in your weather preference, any head injuries recently, and any flu-like illness. Now remember one thing: if your task is take a psychiatric history from the patient, then you need to ask all these things like heads, SADMA, past medical, family history. That's the important thing to ask at that time. But if your task is take mental status examination or do mental status examination with this patient and present mental status exam to the examiner, in that case, you can actually finish in the cognition in here, and lastly, you can just ask any other medical condition or mental illness, any family history of mental illness, and you can just stop there. You don't need to ask head, SADMA, all of it, if MSc is the only task. That's how you manage your time. Depending on the task, you have to cut short your history sometimes. So if we give a summary of all these things, so in psychosocial history, you start with confidentiality, then you go for mood, sleep, and appetite, suicidal risk, hallucination, delusion, insight, cognition, judgment, heads, SADMA, past medical history, family history, organic cause. That's the format of every psychiatric history you will need. But sometimes we will add something, we will cut something. Now, this is the MSc format. When you present MSc to your examiner, you need to have this format with you. So what is the MSc format? So the mnemonic will help you to remember it. And I would advise when you go for your exam, they allow you to keep a pen and paper in front of you. You can't write anything in the initial 2 minutes, but in the 8-minute time, you will be able to write anything you want. But don't write too much because you will just waste your time. But in case of MSc presentation, at least write aseptic J3R in the paper and just write the positive finding when you are taking the history. So what is aseptic J3R? A for appearance and behavior of the patient, then S for speech, emotion. Emotion has mood and affect. We will discuss that. Then P for perception, that's your hallucination. Then there is another T, thought form. We will discuss that. Thought content is your delusion. So you have to remember there is 2T in here, aseptic. Then you have I for insight, C for cognition, J for judgment. And lastly, 3R. 3R means risk, rapport, and reliability of the patient. So this is all that you need to present to the examiner. If you don't have a format in your head like that, you will miss most of the important thing. And that's how you should present your MSc one by one. Now let's go in detail about these findings so that you know what to say in different cases. So first of all, let's say you have to give a brief introduction to the examiner that what you are going to discuss about. So say that, dear examiner, I would like to present the mental status examination of my patient, Mike, a 35 years old veterinarian doctor found by his partner in the garage trying to hang himself. Okay, so you give a perspective about the patient in the introduction, and then you start your MSc presentation. In my finding, I have found this patient's appearance and like you can say, in terms of his appearance and behavior. So then you discuss about it. So appearance and behavior, you have to include how was the patient looking. So first, if he is dressed appropriate to the weather or not, if the patient well-groomed or unkempt, cooperative or angry, okay, maintaining eye contact or not, very, very important to not to miss this one. And if there is any abnormal body movement or posture. So just by looking at the patient, you will know about all of it. Now, abnormal body movement or posture sometimes define a specific condition. So if someone is in stooped posture and not maintaining eye contact with you, most likely that's depression. Frequent fidgeting of their hands, anxiety. Patient is very restless, not sitting, just running in your room, very agitated. Most likely it's a mania patient. Patient seems distracted and seems to be responding to some unseen stimuli. That's schizophrenia. So you will notice that that patient is looking at the ceiling as if someone is talking with him, but you can't see anyone. So that's called responding to some unseen stimuli. So as I say, that different body movement and posture defines different condition. So if you get anything within the conversation with the patient, you have to include that in your appearance and behavior. So you say that in terms of appearance and behavior, he is dressed appropriate to the weather, he is well-groomed, was cooperative, and maintaining eye contact with me. And there was no abnormal body movement or posture. If there is a positive finding, you include it here. I will show you at the end that how you should present MSc altogether. After appearance and behavior, that's your A. Then S for speech. So in the speech, you try to find out if this patient is talking in a normal rate, volume, and tone, or if this patient talking very slowly and monotonous. Slow monotonous speech is usually present in depressed patient. Monotonous means that if you just ask that, how's your mood? Patient says low. How's your sleep? Okay. Do you have any suicidal thought? No. So just one answer, one word answer of every question, that's your monotonous. So patient who is very depressed will be having this slow and monotonous speech. On the contrary, if it's very rapid, loud, and pressured speech, that's your mania patient. So mania patient will talk very loudly, very rapidly, and that's what we call as a rapid pressured speech in mania. Patient with depression sometimes also will talk with pauses in between. Many a patient will not answer question appropriately because they will just talk and talk and talk. And in case of psychotic patient, you can get some disorganized speech also, that you can't understand what they're talking. So that's speech you need to include. So usually we can say that in terms of his speech, it was normal in rate, volume, and tone, but there was no slow monotonous speech or rapid pressured speech. Sometimes giving a negative finding during your MSc presentation shows the examiner that you know this thing pretty well. So after the speech, then your E is for emotion. Emotion includes two things, as I discussed, mood and affect. Mood is something what patient says about their mood. So if when you ask, how's your mood? Patient says, all right. That's the patient's mood. So you say, according to the patient, his mood is all right. Now, what is affect? Affect is what you observe in the patient. If you see that patient actually looks all right, then you say affect is congruent with his mood. If patient says mood is all right, but patient is crying in front of you, that's the affect is not all right. Then you say affect that I have observed is not congruent with his mood because he was crying in front of me. Okay, so that's how you say about the affect. Affect is what you as an examiner or you as a doctor observe in a patient. Then go to the perception. Any question about mood and affect? A lot of candidates get it wrong in the exam. So you guys have any question with this one? Great. So you have done your appearance and behavior, is speech and emotion. The next one is P for perception. So you just discuss that if this patient having any perceptual problem, like any hallucination or not. If you get positive, then you can say, in terms of his perception, he was having auditory hallucination, but there was no visual or tactile hallucination. So that's perception. After perception, then there is 2T. One is thought form, another thought content. Now, thought form will make you a little confused, even in the exam. So thought form means that are you able to understand what patient is saying? If you can understand it properly, their thought form is linear. So linear thought form is a normal organized speech or conversation you have with your patient. Even a psychiatric patient can have a linear thought form. It doesn't mean every schizo patient will have disorganized speech. Okay, so if you can understand their conversation, their thought form is linear. What else can it be? You can get loosening of association, which includes tangentiality and circumstantiality. This is mainly you can find in a schizophrenia patient. So what is loosening of association and what is flight of ideas, which is found in mania patient? These two you need to understand. So loosening of association means there is no association of each sentence they are talking. So one sentence has no relationship with the next sentence. But flight of ideas means there is lack of association, but still there is a little bit of connection in between each of the sentence patient is talking. Let me give some example of it. So let's say loosening of connection or loosening of association. Patient saying that, oh, doctor, I went to the market. I think I should read that book. When did you buy that dress? It's a very lovely evening. Oh, I feel like having a chocolate today. No, I need to study for the examination. Oh, that movie was very good. I think I should go for a walk. So see that every sentence I am saying, it doesn't have any relationship with the next one. And you can't actually make up anything out of that conversation. That's called loosening of association. Now, tangentiality, circumstantiality, not important for your exam, but if you really want to know, tangentiality and circumstantiality, circum you can remember by circle. That means if you ask a question to a patient will say a lot of things, but eventually they will answer your question. So you ask that, oh, how's your mood these days? Patient says, oh, my grandfather was really nice. No, oh, my mother is going to have a date with another person today. Oh, yeah, that movie was really amazing. Oh, yes, doctor, my mood is good now. So eventually I answered the question, right? But in a tangentiality, patient will never ever answer that question. They will just go on and on and on. So that's how you find out if it's a tangentiality or circumstantiality. Don't bother with that. You don't need to go in that deep in the exam. If you can find out if this patient having loosening of association, that's fine. What is flight of ideas? As I say, there will be a little bit of connection in between two sentences they are talking. So see that this one, I loved that movie. I'm going to watch a movie with my mom. My mom adores me. So each of the sentence has some connection. Okay, flight of ideas actually means that the conversation is jumping from one topic to another, making a little connection between each other. But loosening of association, no connection at all. And there is also another thing called concrete thinking. Concrete thinking is that patient doesn't understand some literal question. That means if you say that, how do you feel? Patients say, I feel with my fingers and my toes. So that's their question. So they don't understand the way of conversation. So that's called concrete thinking. Now, in case of thought form, most of the time in the exam, you will get a linear thought form, because otherwise how they are going to give you the information, right? So don't bother with that too much. So that's your thought form. Then thought content. Thought content is mainly the delusional question that you asked. If you get any positive finding from that, you can just say that in terms of thought content, my patient was having deletion of reference or deletion of adjudication. Apart from delusion, thought content also include any obsessional thought, like in obsessive compulsive disorder. It also include overvalued ideas, especially you will get it in an eating disorder or body dysmorphic disorder patient. Like they have some overthinking about their body image and shape. So those overvalued ideas also will be included in thought content. After that, then you have cognition, insight, judgment. So you can easily remember. So if you find patient is oriented to time, place, and person, then you can just say that. Insight, judgment. And lastly, you talk about 3R. 3R, risk, rapport, and reliability. In the risk, you find out if this patient is a high risk or low risk. Who are the high risk patient? High risk patients are, most importantly, if someone having active suicidal or homicidal thought, that person is high risk. If someone having active hallucination or active delusion, that's a high risk patient. If someone has lack of insight, poor judgment, lives in the street, no support at all, that's a high risk patient. Okay, so depending on this, if you get anything like that, then you can say patient is high risk. If patient is not, then you can say it's a low risk patient. Rapport is how, like, were you able to maintain a good relationship with the patient? Now, if you were not, that's not a problem, because many a patient will never ever have a good rapport with you. So that's fine. It depends on that. If patient was giving all the information appropriately, and there was a good relationship with you, with your role player, you can say you were able to maintain a good rapport with the patient. Reliability is the history given by your patient reliable or not. Any psychiatric patient, especially if it's an active psychotic patient, their history is never ever reliable. You have to take a collateral history from their relatives, from their partner, or even sometimes a police who brought a patient out of the street. So whoever is with the patient, you need to take a collateral history from them. Depression patient, you can think that their history is reliable. But in mania patient, their history is not reliable most of the time. Okay, so that's your MSc presentation. Remember, you don't need to give any diagnosis in the presentation unless the task asks you to do so. Now, let me show you that how you can give or you can present MSc to the examiner. Let's just assume our patient is a depressed patient, severe depressed patient. So you will say this one like, dear examiner, I would like to present the mental state examination of my patient Mike, who is a 35-year-old patient brought by his partner who was trying to hang himself in the garage today. In terms of his appearance and behavior, he is well dressed, appropriate to the weather, well groomed, cooperative, and was not maintaining any eye contact throughout the conversation. He did not have any abnormal body movement or posture. In terms of his speech, it was slow and monotonous, but there was no disorganized speech or rapid pressured speech. And he was also taking pauses in between most of the time. According to the emotion, in terms of emotion, patient says his mood is low and the affect that I have observed is also congruent with his mood. In terms of perception, he did not have any active hallucinations. His thought form was linear. There was no loosening of association or any flight of ideas. In terms of thought content, he was having delusion of guilt, but there was no delusion of reference, control, or grandiosity. His insight was poor because he did not want any help and he wants to have suicide. Judgment was poor, but he was oriented to time, place, and person. In terms of risk, my patient is a high-risk patient because of active hallucination. I was able to maintain a good rapport with him, and his history was reliable. Thank you, doctor, or thank you, examiner. So that's how you take or how you present your MSc in the exam. Is this understandable, guys? Any questions so far? Any question, guys? So yes, Dr. Cynthia, so if you can't establish rapport with the patient, you just say, I was not able to maintain a good rapport with the patient. The patient was mostly irritable all the time. So that's fine. You will not fail for that because some patients are designed that they will be irritable. So that's not a problem. No, the reliability comes with a collateral history, Dr. Cynthia. That means like if you maintain a good rapport, doesn't bother with the collateral history. If you see that the patient is a psychotic patient having active hallucination or delusion, their history is not reliable, then you say that you want to take a collateral history from their family member, partner, whoever is the carer. And Dr. Afsana, the linear thought form means that if you can understand someone's conversation and patient is answering your questions appropriately, that means this patient having an organized speech. Having an organized speech means they have a linear thought form. That means that's a normal finding. Yeah, Dr. Bayan, yes, this lecture will be in the Facebook group. You can listen it again. That's fine. And also it will be uploaded in the YouTube. You can also go through that. All good. Guys, I want you to just to remember what we have discussed so far. Try to remember the aseptic J3R, and we are going to take a 5-minute break. And once the 5 minute is up, I'll start and just go through some of the MSc cases that is important for your exam. Today, we are not going for the role play of the MSc cases. There is a class just for MSc role play, and that will be your first class of the first free 2-week session. So we will keep that one, but let's just discuss 2-3 cases of MSc just to show you how it can come in your exam. Okay, and if any of you wants to do role play, I am more than happy to help. Okay, so let's take a 10-minute break. Not 10 minutes, let's take a 5-minute break today. Okay. And then I will again start. Thank you all. All right, guys, let's start it again. So I've got a question. So Dr. Rafia has regarding SADMA and HEADS will include in every MSc. No. So SADMA and HEADS should not be included in every MSc because you will not get that much time in the exam. Psychiatric cases, especially some of the cases like mania, even depression, schizophrenia patient, they can make a lot of time waste initially and during the history time. So you might not get that much time. So if your task says that your task is to present MSc to the examiner, then you don't need to include SADMA heads in that way. But if your task is like take a psychosocial history, give diagnosis and differentials, then you have to include SADMA heads. Okay. All right. So that's important. It depends on how much time you have. So you will understand when you do a lot of role play with your partner. And another thing I forgot to say that the most important part of your preparation is having a dedicated study partner. Now, in your MCQ preparation, you had maybe like 5 or 10 study partner, right? Exam, you should not have more than 3. You like, including you, the group should not be more than 3. Okay, like some of you will have 5, 6. That depends, but in the most or the highest benefit you get out of a three partner role play. 2 partner, okay, if both of you are really dedicated, then that's fine. But most of the time, someone of you will be missing to come to the conversation and doing the role play. That's why a 3 partner group is best. What happens in 3 partner is that if at least 2 people are available, you will start doing your role play. The other person who keep missing and who keep changing the time, he or she will also join you, because then he or she will understand that, well, I'm keeping behind or I'm getting in behind, so I should join them. Otherwise, I have seen a lot of complaint from the study partners that like a lot of cancellation happen, and that's very normal. And once it starts, it will start and go on. So just to avoid those things, I would suggest to have a 3 steady partner in a group and do a lot of role play. You can't think that I will prepare myself initial 3 months and then I know the cases, then I will start doing role play. No, that's no benefit at all. You start your role play first day. Like if today is your first class of any clinical course, your role play starts from tomorrow. Okay, that's how you should do it. Initially, a lot of you will not, you will be funny during the role play. And we know who are beginners, who already have done a course, or who is in the middle. Just by listening to you, I can say who is in where. Okay, so that's fine. As a beginner, you are allowed to stutter, you are allowed to sound funny. Even if you say some other regional accent, that's also fine, because that's how you learn. And once you start doing role play, you learn from your study partner. And in our course, also we have a dedicated role play every week. Okay, so in that role play session, you will get to listen to others, you will get to do role play, and that's how you actually start building up your own thinking. That's really important. And when you join any course for your preparation, if you don't have a partner like this, find one. And we also try to help you to show you who you can go, and if that person matches your time zone and everything. So we will help you to find a role study partner, but obviously you need to come forward for that. All right, Dr. Ashanta, we'll discuss about the course just after finishing these 2 or 3 cases. Okay. Now, let me discuss one of the MSc exam sample cases. So this one is a veterinarian doctor brought by his wife because he was trying to hang himself. with a rope since a cat died during a surgery. So that's one of the question. See the task, perform MSc and present the MSc to the examiner. So that's how your question comes. Now there will be, sometimes they give you more information in the question or a STEM, that's fine, but that's the gist of the question. Let's say these are the positive points. So positive points is this patient having appearance like this, all of these things. We already discussed this case initially when I was actually giving you the MSc presentation. That's the same kind of case. Now, I don't need to go through that again because we already discussed. So you can see that you have to just follow the similar history format, making sure you keep the format of mood, sleep, appetite, and all of it. Then the positive point could be like appearance, patient was having a stooped posture, very gloomy, well-dressed, no eye contact, low mood, speech was monotonous, taking pauses in between, having high suicidal intention. This one is important. He believes that he killed the cat, and that's delusion of guilt. No hallucination, no insight, poor judgment, cognition, okay. Is this patient a high risk or low to moderate risk? What do you think? High risk, right? Obviously high risk patient because of active suicidal ideation, no insight, poor judgment. And obviously he already had a suicidal attempt, so he is high risk. There is another case, let's discuss this one. So you are a HMO in an emergency department of a major hospital, about to see a 28 years old man who had been brought to you by the police from the street. He is a known schizophrenic patient on antipsychotic, but he doesn't take his medication regularly. And sometimes he takes ice. Ice is one of the illicit drug in here. Take further history from him, present MSc to the examiner with risk assessment, tell management to the examiner. Now forget about management. Management usually doesn't come in exam. Usually you get further history and present MSc to the examiner. And sometimes they can ask you to do a risk assessment. I will discuss how to do the risk assessment later on. So now if in here you can see that further history from him, in that case, if you have time, you should ask a little bit about heads, because heads will allow you to do a good risk assessment, because you need to find out if this patient having any support or not, and does the patient has anyone at home. So in this particular case, you can't stop in the cognition part. You have to ask heads, SADMA, because he has a history of ice taking. So in this case, you have to ask all those questions. So as I said initially, case by case, things will be different. So further history is the same thing. So you can say, hi, John, it's very nice to meet you. I'm Dr. Arshan, one of the doctor here. How are you doing these days, John? John will say that, or you can say that, I can see that police has brought you here today. Would you mind telling me what was the reason of that? Patient say, I don't know, I was just roaming around the street. So what you haven't done so far, you haven't given the confidentiality. So patient will not open up to you. Then you give confidentiality, say that, well, John, I need to ask you a few questions, and I want you to know that whatever discussion we are going to have, it's between you and me. I want you to know that you can tell me anything. You don't need to feel judged or blame or embarrassed about anything. I'm here to help you. And please remember, I would not discuss this thing with anyone, even not with the police, unless it is harmful for you or others. So that's how you give a confidentiality statement. Then one by one, you will ask about the mood. So how is your mood these days? Do you feel really low or high at any time? How is your sleep and appetite? Do you feel life is worth living? Have you ever had any thoughts of harming yourself or others? The patient says at that time, no, why I would do that? I am the messenger of God, and God asked me to do good to everybody. That's your clue, the first clue to the diagnosis. So what do you think this patient is having? Messenger of God. God is asking me to do good to everybody. What is this finding called? Delusion of grandiosity, right? So that's, now it can be mania, it can be schizophrenia. Delusion of grandiosity can be present in both of these conditions. So right now you have got a delusion. Now you know that patient saying that I am the messenger of God. So what is your next question? You want to find out that if this patient can see or hear God to rule out hallucination. So John, thank you so much for sharing that with me. I want to ask a little bit more sensitive and screening question. So do you hear God? Yes. How long you were hearing God? It's very important to get a duration, because if diagnosis is a task, according to the duration, your diagnosis will be different. It could be brief psychoactive disorder. It could be schizophreniform disorder. It could be schizophrenia, just depending on the duration. So if it's less than 1 month duration, that's brief psychoactive disorder. 1 month to 6 months, schizophreniform. More than 6 months is schizophrenia. So always ask the duration. Patient says, don't know. If you get auditory hallucination positive, especially from God, always ask about command hallucination. So is there any other commands your God is giving to you? Why you are asking that? Some God, especially according to the psychiatric patient, some God can give command hallucination to kill someone or to do some bad things. So you need to find that out. So very, very important. It's a key step in any kind of auditory hallucination. Ask about command hallucination, that does your God give you any other command? In here, you haven't got anything like that. Any other strange thing that you hear apart from God? So you're trying to find out, is there any other form of auditory hallucination? No. Do you see God? No. So there is no visual hallucination. So you ruled out hallucination, and then you also find out delusion, grandiosity. What you need to do, you need to ask about all other delusion. So do you think someone is trying to spy on you or harm you? Patient says, no, doctor, but all other people are jealous of me. Now, sometimes we call it delusion of jealousy, which can be included in persecutory delusion. So if you say delusion of jealousy, that's also fine. If you say persecutory delusion, that's also fine. You can also ask that, why do you think people are jealous of you? Because I am messenger of God. Okay. Now quickly ask about all the delusional questions. So do not forget about delusion of reference, control, thought broadcasting, okay, thought insertion. All these questions should be asked, because a schizophrenia patient can have any of the delusion. So try to find that out, because if you miss one, you are missing a specific key point. So after delusion, then you ask insight. So do you think you need any professional or any medical help? No, doctor. Ask about the cognition question. Ask about, what will you do if this room catches fire? Patient says nothing, God will save me. So that's a poor judgment. Then you ask about heads. So how's your home situation? Patient said, I don't have any home, I live in the street. Okay, so do you have any support? How do you do you have any financial support? So that's important also. So home support, financial support, you should ask. Ask about their SADMA, so smoking, alcohol, recreational drugs. You already know from the question that patient sometimes take ice To rule out drug-induced psychosis, you should ask, when was the last time you took the ice? Okay. And you can also ask, if you have some time, you can only ask that how many times or how frequent you take it in a week, any other drugs you take. You should also find out that I got to know from the note that you were diagnosed with a condition known as schizophrenia and you were given some medication. Are you still taking that medication? No, doctor. Can I ask why you are not taking it? Always make sure that don't sound judgmental in your conversation. Some candidate will ask that you were given some antipsychotic drug. Why did not you take it? So what you are doing, you are becoming a police with a patient. You are not there to be a police. You are there to be a friend or to be someone who can support their patient. So don't be a lawyer or a police in the exam. A lot of candidate becomes one. Okay, so what you need to do, you need to sound friendly. So say that I got to know from the notes that you were diagnosed with a condition known as schizophrenia and you were given some medication. Can I ask you that, are you taking this medication now? No. I'm really sorry to ask. Please don't get me wrong, but is there any reason why you are not taking this medication? See that how politely we are asking this? That's how you should also. So being polite means a lot, especially in psychiatric cases. Okay, that's how you will get good mark in all the specific key point, and your mark will be really good in approach part. And lastly, just ask about family history, past mental history, all of those things. Then you present your MSc. So say that, dear examiner, I would like to present the mental state examination of my patient, John, a 28-year-old gentleman brought by the police from the street, the reason being unknown. In terms of his behavior and appearance, he was not dressed appropriately. He was unkempt and not well groomed. He was not very cooperative with me, but he was maintaining eye contact and his body postures appears to be okay. The rate, volume, and tone of his speech was normal. The mood, according to him, was okay, but the affect I observed was disturbed, which is not congruent with his mood. The thought form is linear. There was no listening of association, flight of ideas. Regarding thought content, he was having delusion of grandiosity because he thinks he is messenger of God, and also delusion of persecution because he thinks other people are jealous of him. In terms of perception, he was having auditory hallucination because he can hear God, but no command hallucination or visual hallucination. He is oriented to time, place, and person. His insight was poor and also judgment was poor. He was not maintaining a good rapport with me, but his history appears to be unreliable. So I would like to take a collateral history from the police. In terms of risk assessment, in my view, he is high risk patient because he's having a relapse of schizophrenia with active hallucination and delusion. On the top of that, he is living in the street, has no support, he is abusing illicit drug, and also he lacks insight and judgment. So all of this puts him in a high risk criteria. And you finish your presentation in here. Okay, so that's how you should present your MSc. Now you understand that you have to be very fast to finish this in time. Otherwise, it will be really hard. Okay, at least keep 2 to 3 minutes for MSc presentation in the exam, and try to finish your history in 4 minutes or 4.5 minutes. That's highest. Only problem that most of the time you don't know your time and you don't have any watch in the exam. So it's all in your mind. Once you do a role play a lot of time, you will get to understand the timing a lot better. Sometimes management can come in exam, very unlikely, but you should know it. Any schizophrenia or active psychotic patient, there is short-term management and long-term management. In the short term, high-risk patient needs to be admitted in the hospital, even though if patient does not give consent for that, it will be an involuntary admission under mental health team. Okay, so this patient will require admission to the hospital. Even patient doesn't give consent, it will be an involuntary admission. You need to do a complete organic workup, just some basic blood tests like a full blood examination, inflammatory marker, liver kidney function, thyroid function, toxicology screening of blood and urine. Okay, so just a basic blood. You don't need to do a CT scan of brain to everyone, so rule that out. And then if you are in the hospital, you will involve your senior and also you will involve the acute mental health team in the hospital. Acute mental health team comprises of a psychiatrist who will most likely start him on antipsychotic drug. Once patient becomes more stable, then a psychologist will be involved who can give some cognitive behavioral therapy, and also the mental health nurse will assist him during his stay in the hospital. So acute care team will be involved in here. In the long term, this patient will be discharged in the community and the community mental health worker will be involved. If needed, you can also arrange a social worker for him who can take care of this patient in the long run. If patient also have abusing drug, you need to refer this patient to a drug and alcohol rehabilitation center. And then you will write a letter to his GP so that GP can review the patient regularly. Okay. Now, if you're in a GP setting, in that case, you can't involve the mental health team immediately. So in a GP setting, you have to call the acute care team in the hospital. And acute care team, most of the time, they can review the patient over phone and they can take the history. And if they think that patient needs to go to the hospital to be admitted, then they will ask you to send this patient to the hospital. And then in the hospital, this patient will be seen by the mental health team. Okay, so that's your management in just most of the psychiatry management is similar like that. Immediate management and long-term management. Any question, guys? In exams, sometimes you also get video cages. So they give you a video of one doctor and a role player, just a conversation between them. And you need to take note, maybe for 4 minutes, you will listen to the video and take the note, and then you will present the MSc. That's a video format of MSc. We'll do some of the video cases in the role play session, not today. Any of you wants to do a role play? Now, as I said that you can keep it as a delusion of jealousy, that's also fine, but delusion of jealousy, sometimes we also put it in the persecutory delusion. That's just a subtype of it. There is no like particular reason behind it. So usually either you say it's delusion of jealousy or delusion of persecution. Because most of the people who has the persecutory delusion, they think that other people are jealous of him, and that's why they are trying to harm him. That's usually the underlying pathophysiology, you can say. To be more specific, you can use the term delusion of jealousy. Okay, now we are not going to do any of the cages today. Dr. Salma will do the cages in the role play session. So at that time, if anything comes up, you will know. And in the risk assessment, Dr. Rida, we have a format for risk assessment. Usually we call it SAD-Pearson, but that's not needed for your exam. In case of risk assessment, a couple of points that you keep in your head is that, is this patient having active suicidal thought? That's high risk. Is this patient having active hallucination or delusion? That's high risk. If this patient had a previous suicidal attempt and now having active suicidal thought and also having an access to weapon, that's high risk. If this patient has no insight, no judgment, that's high risk. If this patient doesn't have any support and lives in the street, that's high risk. Okay, sad persons or sad persons include all of it. But I don't want any of you guys to remember in that way because it just kills a lot of time in the exam to do that. As long as you are using this point, the examiner knows that you are using sad persons. Okay, now let's just do a role play. I think Dr. Smriti wants to do that. So we can do a role play and see how it goes. So Dr. Can you unmute yourself, or maybe I have to do it. So I'm unmuting you.
Yes, doctor, can you hear me?
I can hear you. So this is your case. Take 2 minutes to think what you want to do, and then we will start.
Okay, all right.
All right. So this patient's name is Sam. You can start. Just 1 second. I will just give you the timing. So you'll get 8 minutes to do this. Let's do it as 7 minutes 30 seconds, but because that's the usual one. Okay. So this patient name is Sam. You can start.
Okay. Oh, hi, this is Dr.
Cockroaches. Too much cockroaches in my body. What's happening in here? Can you just ask someone to clean this room?
I understand, Sam, and I'm really sorry that you had.
No, there is no sorry or apologizing going on. Whoever you are, I can't stay in here. I just need to go home. This place is filthy. Oh, stupid.
Okay, I understand, Sam, and I have already called the cleaner. He's on his way. He will come and clean the room. I'm really sorry that you are going through this. Please
just leave me. Leave me alone. Stupid cockroaches.
Yeah, okay, I understand, Sam. Sam, I'm the HMO in this, Dr. Farhana. I'm the HMO in this surgical ward. And I understand that you are going through this. Please just take a minute. The cleaner is on his way, okay? Now, John,
whatever.
Okay, all right, Sam. I have got to know from the notes that you have dislocated shoulder and you had a surgery. And how is your pain right now, John? Sam?
Yeah, I'm okay, doctor, but these cockroaches are making me really aggressive. I just can't be here. This room is so filthy, so dirty. How a patient can be in this hospital?
Okay, I understand, Sam. Please bear with me. The cleaner is on his way. He will come as early as possible and will clean the room. All right, Sam? Now, Sam,
Okay.
I'd like to ask a few questions and so that I can understand what's going on. And please let me assure you, whatever I'm going to discuss, that's going to remain confidential, okay?
Okay.
All right. As a Sam, you are seeing the cockroaches. Can you feel that it is also crawling on you?
Yeah, it's all over my body. There is one in your shoulder, doctor. Just in your left one. Oh my God.
Yeah,
Just
thank you
in your
so much. Thank you so much, Sam, for pointing that. I'll clean that as well, okay? And apart from that, Sam, I'd like to ask a few questions that might seem a bit strange to you. Those are just screening questions. Sam, do you hear, apart from that, do you hear, feel, or see things that others don't?
No, what do you think? Am I a crazy person? I'm not crazy, doctor.
No, no, Sam, as I have told you, those are just screening questions, okay? Please bear with me. And apart from that, do you think someone is spying on you or trying to harm you?
No.
Okay, do you feel guilty of anything?
No, why I would feel guilty? The hospital and you should feel guilty about what you were doing to me. There are stupid cockroaches in my body. They're just crawling all over.
Okay, I understand, John. Sam. And Sam, can you please tell me how is your mood nowadays?
Yeah, it's okay.
How is your sleep and appetite?
Yeah, it's just all right, I would say.
Okay, and do you have any passing thought of harming yourself or others?
No?
Okay, and do you have enough support?
Yeah, I have.
Okay, and do you think you need medical help?
Why I would need medical help? I don't know. I'm in a hospital already, and on the top of that, these stupid cockroaches are everywhere. Somebody need help me. Like the cleaner needs to come here now. Otherwise, what's going to happen?
Yeah, I understand, Sam. Cleaner is on his way. He'll come and clean the room. Okay, don't worry about that. Sam, can you please tell me if this room catches fire, what you gonna do?
Is there a fire in this room also? Oh my God, what's happening to
No,
this
no,
place?
Sam. This is just a question that I have to ask all my patient. Please don't panic. Don't worry about that. Okay.
I'm not panicking, doctor. Anyone would panic in this situation. There is a cockroach on your shoulder. How
Yeah, I
you would really.
understand. Yeah, don't worry, Sam. I will clean that. Okay. And apart from that, John, do you smoke or drink? Do you smoke or take any recreational drug?
Yeah, I don't do smoking, but I drink alcohol sometimes.
Okay. And for how long you have been taking alcohol?
30 years.
And how many drinks do you have per day?
Uh, times 10.
Okay. And do you take any recreational drugs?
No.
All right. And another thing, where are you right now and who am I? Can you please tell me?
I'm in the filthy hospital and you are the doctor.
Okay. All right. And do you have any weather preference, Sam?
No.
Okay. All right. Thank you so much for the detailed history, Sam. Examiner, I'd like to present the mental state examination of my patient Sam, who is a 47-year-old male and had a surgery for his dislocated shoulder. He's dressed appropriate to the weather, and he's maintaining eye contact, but he's not that much cooperative, and he's very restless and anxious. And and he is distracted by the surroundings. And in terms of his speech, his speech is high pressured, and according to him, his mood is okay, and the effect I found is congruent with his mood. And in terms of perception, he is having visual hallucination and tactile hallucination. And in terms of thought form, his thought form is linear, and his thought content is normal as well, because he's not having any active delusion. And his insight is impaired, because he thinks he doesn't need any kind of medical help. And his cognition and judgment is poor as well. His cognition is intact, but judgment is poor. And I was not able to maintain that much rapport throughout the conversation. And his history is not reliable. So I'd like to take more history. I'd like to go through his past medical history, surgical history, his operation notes, and other surgical notes as well. And in terms of risk assessment, I think he's at medium to high risk, because he's having active hallucination, and his cognition and insight is poor. Okay, thank you so much.
All right, thank you, Dr. Smriti. It was really good. I'm really amazed about that. Like, you were really good, and I understand that the way you did it, I think like you were very confident, and did not get perplexed by the role player at all. And that's really important. In this case, the role player is much more disturbing than what I was. So the many candidates just lose their nerve, because they just like make you feel really disturbed. So it's good that you know how to deal with this sort of difficult situation and difficult cases. Okay, so only what I found that you should not do is that don't say to a patient that do not panic. You can immediately fail just because of that sentence. Okay, do not
can
ever
I say just can you please don't panic?
No.
Okay,
no.
Right.
Say, because
actually I don't at that time I don't know what to say. I just say it from out of nowhere.
Yeah, I know this happens. This is how like sometimes we just say something, we even we don't mean it. But the thing is that in here, it's like if we say that, oh, you're just panicking, sometimes it sounds very judgmental. So patient feel it judgmental if you say that. So just say that just how you did that was fine. Do not say the word that do not panic. Say that it's going to the cleaner is coming, please understand, he's just on the way. Just anyhow manage the situation, but don't say like calm down, don't say panic. Those things can ruin your whole case.
Okay, all right. Okay. And I was just keep saying calling him John. I just
Oh yeah, I know.
Is it gonna fail me as well?
Not likely, as long as you say sorry. At least say, oh, I'm really sorry that I kept saying you John. And you can make these things like very funny in front of the examiner, that you kept saying him John. That's fine, as long as you say that yes, I'm doing it wrong. They are good. But if you don't say sorry, you keep saying them John, then it can impact.
Okay, all right, thank you.
Okay, I think like you did really good. You did not miss any specific point. So that's really perfect.
Okay, thank you so much.
Just forget, like, did you give the confidentiality statement initially?
Yeah, I did.
Yeah, I think you did. Yeah. All right. So that should be fine. Thank you so much, Dr. Smriti.
Thank you, doctor.
Yeah. So this case is about delirium also. So it's an alcohol withdrawal causing delirium to this patient, most likely. But they don't ask you to give diagnosis differential in here. They just want you to present the MSc. So differential diagnosis will be the whole delirium thing. So what are the causes of delirium? Will all of these things come in the differential? Okay. Yes, if examiner says, Dr. Oishe, if it's not examiner never says time up, you will get a clock saying that time up, especially like when the time up, you will get an alarm. When you get that alarm or just a bell ring, sometimes you just stop there. Okay, don't continue. But sometimes we used to do that in face-to-face exam. If you, like I always say, stand up when your time is up, and on the way to your, like leaving the room, if you think you missed some very important thing that might fail you, take the chance to say that. Okay, especially in MSc, if you don't say the positive finding and your bell rang, if you leave the room, you fail the case. On the, like, you should not sit at that time. You stand up on the way to your leaving the room, say that, yes, my patient also was having active suicidal thoughts, so he is a high risk patient. Some examiner, if they are really, really gentle and they are not like that much hard examiner, they might even take it into account. So why not taking that chance? And delirium has a lot of differential diagnoses, Dr. Asma. So try to say alcohol withdrawal causing the delirium. That's the first thing that you would say. Try to say that it could be any infection anywhere that can cause it. Hypoxia can cause it. CNS, CVS causes will come into play. Electrolyte imbalance come into play. So a lot of things we will discuss in the delirium cluster, which will be as a differential diagnosis in here. Sometimes even the painkiller patient is taking, that can make these things worse. Okay, so, or sometimes excess pain after surgery can be a cause of delirium. So we just need to include all the delirium differentials. No, we don't need to ask any more history of alcohol in this particular case, because you will not have time for that. If you get someone who is alcoholic like this, you need to arrange another counseling for further assessment and management, just on the alcohol part. Yes, you should, Dr. Ashanka. Keep the patient comfortable, keep the patient reassured that their concern will be addressed. Otherwise, they will not even answer your question. So the way Dr. Smithy has done, that's the perfect way to do that. So say that, I'm really sorry that this is happening to you. I just called the cleaner. He's on the way and he's going to clean the room for you. Please bear with me for a few more minutes. Okay, keep doing this thing and trying to find out the answer from him. That's how you do. I don't think, Dr. Afsana, it will be a good idea that you are doing good. He is not doing good, obviously, we can say. But I think try not to say that he's panicking. Always say that, I'm really sorry that this is happening to you. I'm really sorry that you can feel the cockroaches crawling on you. Okay, please bear with me. It will be cleaned up. So keep saying in different ways. Do not say that you can see the cockroach, you can feel the cockroach. Okay, don't say, oh yes, there is a cockroach I can see. Then that means you are also having a psychotic attack. So you can always make the patient comfortable, but don't say that you can also see the cockroach or you can also feel it. There is a difference between these two. All right, guys. So I think like that's all the today's session that we wanted to go for. I wanted to show you our course detail so that you can understand what the entitles. And once we do that, then you can ask me a question about the course and I'll be happy to answer. Just give me one moment. Okay, so I want you guys to just go through this video. This video shows the course contents and also our reviews and everything. And then we will discuss about the course if you guys have any questions about it. All right, so that was actually all about the course that's going to happen. And that's starting from 31st of January. Will go on for 5 months. All right. And I know that some of you asked me about the class time. So class time is actually, we take it on Saturday, Sunday, and Wednesday. So Saturday and Wednesday is my class. And there is a role play class, which usually taken by usually at the moment is Dr. Sinthi is taking it. So sometimes maybe another doctor can also take it. Usually the recently passed doctors or doctors who are working in hospitals or as a GP in here, they will take the role play sessions. And sometimes I might also take a few. So that's how we usually do it. 3 classes in a week, 2 classes on theory, 1 on role play on the recent cases. And like usually it helps you to go through the questions, and we give you random cases just to do role play in front of us, just to break that fear of questions. Okay, once you get to know the questions, once you get that I can answer any questions that come in front of me, then you are confident for the exam. Now, Sunday, still it's not fixed, I would say, because it depends on the schedule. Sunday or Tuesday is the most likely chance. They can have some alterations because we work in here. So in terms of working, sometimes it's not like very usual, but sometimes there can be. But obviously there is a recording. Just in 24 hours in the software, you'll get the recording, the video recording of the class. In case you miss any class, you can easily go through that. Okay, so that's how it works. Any question, guys, about the course or anything? There is the 2 weeks free sessions coming up from 31st January. You will get the schedule of it in the Facebook group. So please keep an eye on it. The class will be exactly like this, but normally we'll discuss a cluster, start with a cardiology cluster, and we'll finish one of the cardiology cluster throughout the free sessions. And also there will be MSc role play sessions. And at the moment, the admission is going on. As you know, that this course only happens twice in a year. So a lot of candidates join the course, sometimes even in the middle of the course, because we don't run like every 2 or 3 months. We run every like twice in a year. So there will be a lot of candidates who will join. So you will get a lot of chance to get someone to be your study partner and get to know from others. And you will end up meeting a lot of people around you, and you're making a lot of friends as well. And from a course, you make your lifelong friends also. Okay, so always try to utilize those things. It's not about just reading alone in this kind of exam. It's also keeping your eyes and ears open, trying to learn from others, and also helping others in the same way. That's how it works. I hope all of your journey goes well. Even though it's a COVID situation, don't lose hope. If you are overseas doctor, don't lose hope. Keep up. If you're doing a hospital work, keep up doing that. Keep up your preparation. Once your time is up, like once you will get your time to appear the exam, you will know, and most likely you will also pass the exam. It's always important to pass AMC clinical. If you think that, well, let's try for going for a job hunting, it's hard to get a job in part 1. It's not impossible, people get it, but it's hard. But once you pass the clinical exam, job becomes very easy to get. Again, sometimes it can be tricky. It depends on person to person, but it becomes a lot easier to get a job in here by a part 2 exam. And Dr. Shumi, good question. Usually you don't need any book for clinical preparation. It's all the course note that you are going to get. That's the only material that you will need. There is no specific book needed. And only one thing that you need to also study by yourself is that your handbook of AMC clinical. If you are actually waiting for the 31st January course to start, during this time, start the handbook, read the handbook, it will give you a good idea. Handbook cases are very important, so you should at least know the important cases out of the handbook. Okay, so no need of any other study material apart from our course note and the handbook of clinical. That's the only thing. Don't go for a lot of notes. It's not needed. No, the role play class on Sunday, that's a random one. It's not on the system that you do on weekend. Okay, the theory class that I take, I also take a role play on that theory after finishing that. So there are two kinds of role play that we do. One is subjective role play, like let's say we have done the MSc cluster today, and I will do a MSc role play with you. That's subjective role play. And also you will get a sample new cases role play on every week. That's actually a random cases which are important for your exam. Initially it will be hard, but in 1 or 2 months, you will feel the importance of it. Normally, I say that once you finish the course, you should keep at least 1 or 2 months to revise it. So normally, if you take 6 months for your whole preparation, that's the ultimate goal. And if you actually finish everything that we are doing, and you keep your eyes and ears open about the exam, 6 months is the minimum time you should take, in my view. Some candidates say that they appear in 3 months. I don't believe that, and you should not also. Okay, maybe they just told you the time that they have actually prepared or actually they studied, but maybe before that they already knew the cases, they already did the whole lot of things in the last 2-3 months. So 3 months is not enough. You should take at least 5 to 6 months for your preparation of clinical. And the safer approach is, after the 5-month course, take at least 1 or 2 months to revise it and then go for the exam. All good. So let's finish it here tonight. We'll again see you once the free classes come out. If you guys want to join the course, feel free to send us email in the email address that we have given in our Facebook group, or also you can inbox me. So in that case, in that way, you can start it, because once you say that you want to join the course, at least you should keep 1 to 2 weeks in your hand to get the full access, because it takes some time to get into the course. And because a lot of candidates at the same time is joining the course, sometimes there can be a little delay in the first. So that's why if you start your joining right now, by the time when the course starts, you will be all done and you can just start your preparation at that time. Okay, so let's not talk anymore. I hope you enjoyed the session. If there is any questions about the MSc, feel free to ask me in the role play session. Okay, thank you all. Have a good night. Bye.